Hello, good evening all. We are going to commence our lecture. For the benefit of those who missed the last lecture, we are going to revise, then we continue from where we stopped. Last week, we talked about the anatomy of the thyroid gland. We talked about thyroid gland. Then we discussed multinodular goiter. That is where we stopped. So we are going to discuss toxic goiters. Then we will talk about the management generally. And in another session, we'll discuss malignant goiters. Then we'll talk about thyroidectomy in another session. And lastly, we'll end the session for thyroid diseases with multiple choice questions on thyroid gland and disorders. So as a way of revision, we mentioned the embryology of the thyroid gland, and we said the thyroid gland appears at the end of the 4th week of embryonic life from the median bud in the floor of the pharynx at the level of the first pharyngeal pouch at the foramen cecum. Now you should know that at the 4th week of the embryonic life, if you remember the pharyngeal arches and pouches, okay, these are the arches and the pouches are inner part, and this is the floor of the pharynx. Okay, at the level of the foramen cecum, a median bud develops at the level of this foramen cecum, the tongue, and it descends down. Okay. So its position, the final position of the thyroid glands at the 7th week. Okay, this is the first pharyngeal pouch. This is the first pouch at the level of the foramen cecum, and this median bud appear at the 4th week of the intrauterine life. Okay, so at the floor of the pharynx, at the level of the first pharyngeal pouch at the foramen cecum, the thyroid descends in front of the pharyngeal gut as a bilobe structure. It passes in close continuity with and sometimes through the developing thyroid cartilage. Okay, so you should know that this thyroid gland, if you remember the position of the foramen cecum, okay, if you remember the position of the foramen cecum, let's just briefly, if this is the tooth, this is the lower jaw, and if the tongue is here, you have the anterior 2/3, the posterior 1/3. This is the epiglottis. Okay, the foramen cecum is here. Okay, and this descends down. It descends in front of the hyoid bone. If this is the hyoid bone, it can even pass through the hyoid bone. Okay? Then it descends to its final position in front of the trachea. I remember the thyroid cartilage. The thyroid cartilage is here. Okay? The thyroid cartilage is here. And this is the thyroid cartilage. And you have the trachea. Okay? You know the cricoid cartilage is here. Let's say this is the position of the cricoid cartilage. Then if this is the position of the final position of the thyroid gland, you can see it descend from the foramen cecum through the thyroglossal duct and in front of the trachea. Okay, so the thyroid descends in front of the pharyngeal gut as a bilobe structure. It passes in close continuity with and sometimes through the developing thyroid cartilage. The thyroid reaches its final position in front of the trachea by the 7th week. The central column, which becomes thyroglossal duct, gets absorbed. Okay? It is when that central column through which the thyroid gland descent persists. Okay, it persists at the thyroglossal duct. Now, the parafollicular cells, as we mentioned, the parafollicular cells from the neural crest cells. You know, these parafollicular cells, the origin are from the ectoderm. Okay, the neural crest cells originate from the ectoderm. They reach the thyroid via the ultimobranchial body, and their role is secretion of calcitonin. Okay, so this is a brief note on the embryology of the thyroid gland. Now, regarding the anatomy, we said the thyroid consists of two lobes. It's a pear-shaped organ that has two lobes and connected by the isthmus. We said this thyroid gland is a butterfly-shaped or a pear-shaped organ in front of the trachea. Okay, it has the right and the left lobe connected by the isthmus in front of the trachea. And we said this isthmus extend from the second, the fourth tracheal ring, and this lobe ends at the fifth tracheal ring. Now you should know the size. The normal size of the gland is 7 to 25 grams, but in Caucasians is slightly bigger than in the Africans or Afro-Americans. Now, in the Caucasian, the normal size is about 20 to 25 grams. You can see in the blacks, it can go as small as 7 grams. Okay? Now, the gland is limited above by the insertion of the sternothyroid muscle onto the thyroid cartilage, and its base extends to the level of the fifth tracheal ring. The thyroid is enclosed in a delineated layer of connective tissue that forms the true capsule. Now, you should know that this thyroid gland has a true capsule that directly covers the surface of the gland. Okay? Now, it is encased within the pretracheal fascia, which is the false capsule of the gland. Now, because the thyroid gland is encased within the pretracheal fascia, it moves with deglutition. All swellings that are within the pretracheal fascia, they move with deglutition. Being it the thyroid gland, thyroglossal cyst, pretracheal lymph node, subhyoid bursa, whatsoever it is, if it is within the pretracheal fascia, they move with deglutition. Now, this thyroid gland is attached to the trachea by the suspensory ligament of Berry. Okay, a strong condensed connective tissue binds the gland firmly to each side of the cricoid cartilage. Now, you see sometimes during thyroidectomy, this ligament of Berry might acquire some blood vessels, and after excision of the gland, you will see them oozing, for which you have to secure hemostasis. And you should also know that about the isthmus might be connected to a pyramidal lobe, which is absent in about 50% of cases. Now, what is the arterial supply of the thyroid gland? The main supply of the thyroid gland is from the superior thyroid artery. Okay, is the dominant supply of the gland. It's a branch of the external carotid artery. Okay, it comes through the gland via the superior pole of the gland. It is also supplied by the inferior thyroid artery, a branch of thyrocervical trunk, which is from the first part of the subclavian artery. This inferior thyroid artery comes from behind the gland, and it divides into 4 to 5 branches. And through these branches, the recurrent laryngeal nerve pass through the midst of this. The thyroidema artery also supplies the thyroid gland. It is seen in 2 to 3% of cases. Okay, it is a branch from either the brachiocephalic trunk or direct branch from the arch of the aorta. What are the venous drainage of the thyroid gland? Now, the superior thyroid vein, it goes along with the superior thyroid artery, so they are termed the married vessels. The middle thyroid vein is single, and it occurs in 30% of of cases, and its presence sometimes makes it difficult for mobilization of the gland during thyroidectomy. The inferior thyroid vein runs separate from the inferior thyroid artery. They are termed divorced, and rarely you could have a coccus vein draining the thyroid artery. The nerves that are related to the gland are the external laryngeal nerve, the external branch of the superior laryngeal nerve, a branch of the vagus, and the recurrent laryngeal nerve, also a branch of the vagus. It comes amidst the branches of the inferior thyroid artery and runs in the groove between the trachea and the esophagus, and it runs also in the Simon's triangle. You go and check your anatomy of the Simon's triangle. The lymphatic drainage, briefly, the Delphian lymph nodes, the pretracheal lymph node, and the superior cervical lymph nodes. Okay, we also talked about the physiology of the gland. The thyroid gland produces triiodothyronine T3, tetraiodothyronine or thyroxine T4, and calcitonin, which is produced from the parafollicular cells. The T3 and the T4 affects metabolism, growth, and differentiation. Okay, and the synthesis of these hormones depends on the bioavailability of iodine, which we will see shortly. Okay, now iodine metabolism. Dietary iodine is absorbed as iodide, and the daily requirement is about 100 to 120 microgram, okay, per day. Now, it is absorbed from the stomach and upper gastrointestinal tract. 2/3 is excreted via the kidney and 1/3 trapped in the thyroid gland, which stores almost 90 to 95% of the body iodine. You should know that the thyroid gland is the main store for body iodine. Now you should know the dietary iodine is absorbed as iodide. It is absorbed as iodide. Now, let us see how the hormones are synthesized and how they are stored. Now, this iodide is concentrated into the follicular cells of the gland. Okay, the gland has several follicular cells, okay, around colloids. You see, these are follicles. There are multiple follicles within the gland. Okay, now you have the follicular cells, the colloids, as well as the parafollicular cells that secretes calcitonin. Now, the iodine is concentrated in as iodide in the follicular cells. Now, this is stimulated by thyroid stimulating hormone. Now, the thyroid stimulating hormone that is produced from the anterior pituitary gland under the influence of thyroid releasing hormone stimulate the gland to produce the hormone. Okay, stimulus will cause absorption of the iodide by the follicular cells for production of the hormone. And this process, you should know, is inhibited by perchlorates, pertechnetate, or thiocyanates. All those drugs or food products that have these can serve as goitrogens that prevent uptake of iodine. So you should know the first step is concentration of iodide within follicular cells. Now, this iodide have to be oxidized into iodine. So the next step is oxidation of iodide to iodine, okay? And this process is catalyzed by thyroid peroxidase. And this thyroid peroxidase is a target for some of the drugs used in the treatment of thyroid toxicosis. Okay? Now, the next step is the iodination of tyrosine, an amino acid. Now, the next step is iodination, combination of this iodine and tyrosine. Okay? Now, binding of this active form, that is the iodine to tyrosine, within the thyroglobulin form mono and diiodotyrosine. Now, when you have one iodine coupling with tyrosine, you have monoiodotyrosine. When you have two iodine coupling with tyrosine, you have diiodotyrosine. Now, there is formation of both mono and diiodotyrosine. The next is now coupling of this the iodotyronases, the mono and diiodotyrosine. Now, you should know, aside formation of these hormones, mono and diiodotyrosine are also end products. but however, they also undergo coupling, okay, to form iodothyronines, either the tri-iodothyronine or tetraiodothyronine, which is the thyroxine, okay? So what we mean here is when you have monoiodothyronine, okay, coupling with diiodothyronine, you have triiodothyronine, which is the active form of the hormone. When you have diiodothyroxine coupling with another diiodothyroxine within the colloids, they form thyroxine, T4, which is tetraiodothyronine. Okay, so the first step is concentration of iodide in the follicular cells. Second step is oxidation of iodide. The third step is iodination of tyrosine. And the fourth step is coupling of iodotyrosinases to form iodothyronines. Next is the storage. Now you should know that T3 and T4 bound to thyroglobulin and stored in the colloid of the thyroid follicles. Colloid is taken up by follicular cells in packets fused with lysosomes and release of T3 and T4, including the mono and diiodothyronine molecules. Okay, so the lysosomes within these cells take up globulin that contain the hormones, then it releases the hormones from the globulin. All the iodothyronines, mono, di, tri, and tetra, are released. However, you should know that it is the T3 and T4 that are released into the bloodstream, while mono and diiodothyronine undergo deiodination into the iodine and tyrosine and are reused for the synthesis of the hormone. And you should know, we mentioned that T3 is the active form, okay? So there is peripheral conversion of T4 to T3 by deiodination, release of iodine, okay? Now, when these hormones are released in the body, you should know that they are free hormones and they are bound. About 99.9% of the hormones are bound to thyroid binding globulin, prealbumin and albumin. Then you have 0.02% are the free form of the hormone, and these are the physiologically active one. You should know it is only the free T3 and T4 that are the metabolically active hormone. And T3 is 3 to 5 times more active than T4. So 75% of T3 is produced by extrathyroidal conversion of T4 to T3. Now, this deiodination is catalyzed by 5-deiodinase, which you have two types, type 1 and 2. They are found in different parts of the body. T3 acts on receptors found in almost all tissues except from few tissues like the matured brain, uterus, and so on. Okay? Now, the regulation of this hormone is under the influence, as we mentioned, by the thyroid stimulating hormone under the influence of the thyroid releasing hormone that is produced from the hypothalamus, and there is a negative feedback mechanism that controls the production of the hormone. Now, when you do thyroid function test, you should know you are assessing T3, T4, and TSH, and you can also assess for calcitonin which the primary role is to decrease the level of serum calcium. You can also do thyroid autoantibodies, like in autoimmune thyroid conditions, like in Hashimoto's thyroiditis, where the autoimmune antibodies are more than 90%. 80% of patients with Graves' disease have antimicrosomal antibodies. Thyroid scintigraphy also is done for the evaluation, where you see either a hot, warm, or cold nodule. We will discuss this in due course. So these are the various interpretations of diseases you see. In thyrotoxicosis, the T3 is elevated, T4 is elevated, TSH is suppressed. In hypothyroidism, you have T3 low, T4 low, TSH is elevated. In T3 toxicity, isolated T3 toxicity, okay, T3 is elevated, T4 is normal, TSH is suppressed. You can also have an isolated T4 toxicity, which is seen in drug-induced thyrotoxicosis, where the rate of conversion of T3 to T4 is less than the rate of production of the hormone from ingestion of the drug. Now we'll talk about classification of goiters. Goiters simply mean an abnormally enlarged thyroid gland. Normally, a thyroid gland is not supposed to be visible. When it is visible, it means it is enlarged. So an enlarged thyroid gland is termed goiter. Goiters are classified into simple goiters, okay, toxic goiters, neoplastic goiters, inflammatory goiters. Now, when you say simple goiter is a goiter without hypofunction, neither is it malignant, okay? A simple goiter is a goiter without symptoms of hyperthyroidism or hypothyroidism, neither is it malignant. And generally, they are either diffuse or nodular, okay? They can be a diffuse colloid goiter, okay, or a nodular goiter. This diffuse colloid could be a physiologic goiter, okay, and it could be seen in conditions with increased metabolic demands because, of course, the hormones that are produced, the T3 hormones, the thyroxine, they increase oxygen utilization by body cells. So there's increased metabolism, okay? And they also potentiate the action of catecholamines in some certain body organs like the heart and the blood vessels, okay? So you could see a diffuse colloid goiter in enlarged physiologic goiters that will tend to regress after the demand is no longer required, as in puberty, pregnancy, during breastfeeding, and so on. Now, generally, simple goiters could either be endemic or sporadic. You can see them as an endemic entities or sporadic entities. When you say endemic goiters, they are goiters that affect 10% of the population in a community, meaning there's a risk factor in that community that predisposes up to 10% of population in that community. Example, iodine deficiency is a common cause of endemic goiter. Sporadic goiters occur randomly in a community. Okay. Now, toxic goiters could either be a diffuse toxic goiters that are termed Graves' disease. They could be toxic nodular goiters, the plumber's disease. We are going to see them. Then it could be a toxic nodule. And you should know the difference between a toxic nodule, okay, a solitary nodule, and a dominant nodule, okay? You should check the difference between a solitary nodule and a dominant nodule, okay? Here you have an isolated nodule in an otherwise normal gland, okay? Here you have a more prominent nodule in a diseased gland, an already diseased gland. So you should read about the two. So toxic goiters could be diffuse toxic goiters, toxic nodular goiters. It could be toxic nodule, and rarely, okay, rarely less than 5%, you can have toxic malignant nodule. Now, neoplastic goiters could either be benign or malignant neoplasms, and the common malignant ones are follicular thyroid cancer, commoner in West African region, papillary thyroid cancer, which is commoner worldwide, the medullary thyroid cancer, and we have the anaplastic. Now, we are going to take malignant goiters in a separate session, but you should know that these follicular thyroid cancers, they are usually from a long-standing multinodular goiter, and their spread is via hematogenous spread. The papillary thyroid cancers, usually from exposure to radiation, they are slow-growing, indolent, and their spread is via lymphatics, okay? The medullary thyroid cancers, they are the ones associated with the Men's syndrome. Anaplastic goiters are more aggressive and they can cause airway obstruction. Now, the next classification of goiter is inflammatory goiters, autoimmune thyroiditis like Hashimoto's thyroiditis, acute suppurative thyroiditis, where you have thyroid abscess, okay? They are acute suppurative thyroiditis. And usually when there is bleeding, okay, into a nodule and a superimposed infection, it could form a suppurative thyroiditis, which needs an initial incision and drainage. The subacute thyroiditis are not as aggressive, the features of inflammation are usually less than the acute suppurative, and usually it's following like the viral infection, okay, can lead to subacute thyroiditis. The Duquesnean thyroiditis is an entity of subacute thyroiditis that usually follows viral infection. The Riedl's thyroiditis is also an inflammatory thyroiditis that is associated with fibrosis. This fibrosis can cause even obstructive symptoms, okay? Specific infective thyroiditis usually is thyroiditis following specific infections like tuberculosis. So these are the various classes of an anterior neck swelling. We said they could either be simple, they could be simple, they could be toxic, they could be malignant, and they could be inflammatory. Okay. Now we talked about these several entities. The endemic goiters affect 10% of population in the community. It affects mountainous areas where iodine content of drinking water is particularly low. Administration of iodine, usually as iodized salt, is the cheapest and best prophylaxis. Okay. Now, the familial goiters result from inherited enzymatic defects, dyshomogenesis that may cause impairment of iodine accumulation, agranification or coupling of iodotyrosines in the thyroid gland. Now, sporadic goiters are rare, they occur randomly in the society. Now, we'll talk about endemic multinodular goiter or the non-toxic multinodular goiter. Now, iodine deficiency is the most common cause of endemic goiter. Daily requirements is about 150 to 300 micrograms per day. In endemic areas, daily intake is below 50 micrograms per day. In those areas, infants are born with neurogenic cretinism. Now, sometimes these endemic goiters are as a result of dietary goitrogens, For example, when there is environmental iodine excess, maybe from drug or whatsoever the source may be, and when there is excess of iodine, it might impair the synthesis of iodine, like hunger in the midst of plenty, and that is called Wolff-Chaikov's effect. The Wolff-Chaikov effect is when excessive iodine is preventing uptake and synthesis of iodine. This mechanism is used in one of the treatment modality where Lugol's iodine is administered. Lithium, cyanides from cabbages and cassava, poorly processed cassava, phenols and phytates in industrial waste. They can be a risk factor for non-toxic multinodular goiter. Now, what is the pathogenesis of these multinodular goiters? Now, when there is impairment of hormone synthesis, the TSH persistently stimulates the gland to produce the hormone. And of course, the substrate iodine is deficient. Elevated TSH induces diffuse thyroid hyperplasia, followed by area of focal hyperplasia with necrosis and hemorrhage. So there's persistent stimulation of the gland to produce hormone. However, the substrate to produce this hormone is deficient. So more and more colloids will be produced and the hormones are not produced. Now, they will now undergo area of proliferation and some area of involution and necrosis. Some areas grow faster while some other areas are regressing, undergoing involution and necrosis. And these will cause varying consistency of the gland. Some areas might even appear cystic, with hemorrhages into these areas. When this stimulus is continuous and repetitive, new area of focal hyperplasia and degeneration may develop. Now the pathology you should know, it may be diffusely enlarged or nodular. So in the early stage, the gland may be hyperplastic and diffusely enlarged. In the multinodular goiters, the nodules vary considerably in size and number and contain colloid. Nodules may transform into adenomas. Formation of cysts with areas of degeneration, hemorrhage, and calcification may be seen. This type of calcification are dystrophic calcification. So long-standing goiters usually present with dystrophic calcification, which appear coarse on X-rays. What are the clinical features of multinodular goiters? Common in middle-aged female with female male of 10 ratio 1 is 10 times commoner in female. It is slow growing, multiple nodules. Recurrent increase in size signifies malignant transformation or hemorrhage, and they may cause tracheal compression, which will present as a positive Coca's sign. Pain is rare and may be due to hemorrhage and rapid enlargement of the gland. Pressure symptoms they produce are dyspnea and dysphagia. Now we'll talk about the toxic goiters, okay? Thyrotoxicosis is the biochemical and clinical complex that results when the tissues are presented with excessive quantities of the thyroid hormone, okay? Of these disorders, Graves' disease, toxic multinodular goiters, and solitary nodules are the most relevant, even though there are other variants. But in the true sense, when you say thyrotoxicosis is the clinical manifestation of hyperthyroidism. Why hyperthyroidism is laboratory elevation of T3 and T4 with depression of TSH. Okay, there are various types: the primary thyrotoxicosis and the secondary thyrotoxicosis. When you say primary thyrotoxicosis, in primary thyrotoxicosis, the symptoms of thyrotoxicosis, okay, symptoms and swelling occur the same time, or the symptoms might even precede the swelling. This is thyrotoxicosis, and you see this in what? Graves' disease. Okay? When you say secondary thyrotoxicosis, okay, the swelling precedes the symptoms of toxicosis. Now, it means that the symptoms of toxicosis develop in an already diseased gland, okay? And you should know that primary thyrotoxicosis affects younger individuals, and they are usually associated with eye signs, while secondary thyrotoxicosis affects more older individuals, middle age, and they present with cardiac signs, thyrocardia. Now, let's talk about diffuse toxic goiter or Graves' disease, which is a primary thyrotoxicosis. It is an autoimmune disease. It is the most common form of thyrotoxicosis. Can occur in any age, but more common in women in the third and fourth decades. It is characterized by ophthalmopathy and sometimes infiltrative dermopathy. Okay, so they are commonly associated with eye signs. The pathogenesis of Graves' disease. Graves' disease, an autoimmune disorder, is caused by thyroid stimulating antibodies. Thyroid stimulating antibodies directed at thyroid stimulating hormone on follicular cells. There is an increased frequency of HLA-DH/DR3, a circulating antibody which stimulates the TSH receptors okay, mimicking all the effect of TSH in the pathogenetic events in Graves' disease. So there is thyroid stimulating immunoglobulins, okay, that mimic TSH. They stimulate the TSH receptors on the thyroid gland. So there are autoantibodies. The patient will be producing a lot of the hormones. Now, ophthalmopathy, activated T cells has been demonstrated in the orbit, okay? Cytokines produced by these T cells stimulate fibroblasts to synthesize and deposit glycosaminoglycan. So there's a retrobulbar deposition of mucopolysaccharides, okay? And these mucopolysaccharide glycosaminoglycans are produced by the fibroblasts under the influence of T cells, the cytokines produced by the T cells. And also you can have deposition of same substances in the pretibial space. The gland is diffuse and smoothly enlarged with an increased vascularity. The gland is diffused, okay, and smoothly enlarged with an increased vascularity. On microscopy, the epithelium is columnar with minimal colloids present. What are the clinical features of thyrotoxicosis, Graves' disease? Now, they have symptoms that are related to hypermetabolisms and symptoms that are related to adrenergic discharge. I told you that these hormones produced by the thyroid gland influence almost all the cells in the body, with exception of few, which I'll ask you in your MCQs. Okay? Now, and they stimulate oxygen utilization by these cells. So they increase cellular metabolism, okay? And they also potentiate the effect of catecholamines in some certain organs in the body. So the hypermetabolism, they will present with heat tolerance, excessive sweating, hunger, and weight loss. They have increased weight loss despite increased appetite, weight loss despite an increased appetite. So the adrenergic discharge will cause nervousness, emotional liability. They quarrel for trivial issues. They have insomnia, tremors, and psychosis can develop, okay? So these patients, they have increased bowel motility, presenting with diarrhea. They have menstrual irregularities. They will be having some gynecological problems like oligomenorrhea, amenorrhea, abortion, and failure to conceive. So thyroid function test is among the investigation you request for infertility. Okay, now they could have cardiac symptoms like dyspnea, palpitations, okay? Cardiac failure may occur, especially in secondary thyrotoxicosis. We said they may have diarrhea, weight loss despite increased appetite, and the musculoskeletal system, they have proximal myopathy. Now you do a general physical examination, the patient will appear anxious, restless, and fidgety. The skin is warm and moist, and the palm with palmar erythema being present in 10% of patients. The hair is fine and silky, fine tremors of the finger and tongue. Now, CVS, they have tachycardia. That's why when you are following up a patient on medical treatment, the important examination you do is to measure the pulse rate, okay? When patient is on antithyroid drugs, you should measure the pulse rate when they are on follow-up, and you ensure it is less than 90 beats per minute. When it's more than 90 beats per minute, they still have tachycardia. They have wide pulse pressure, arterial arrhythmia, systolic murmurs, cardiomegaly, and sometimes heart failure. Okay, neck, you have diffusely enlarged thyroid gland is seen, which may be asymmetrical or symmetrical. Okay, brew is generally present over the gland, signifying that the patient is thyrotoxic. And when you want to auscultate for brew, you use the bell of your stethoscope at the superior pole because it is the more dominant gland, the more dominant artery that supplies the gland, and it is more superficial. So they may have pretibial mixed edema. Now, when you examine the eyes, you check for widening of the palpebral fissures, okay? Usually, the eyeball, when you examine the eye, this is what you are supposed to see. There shouldn't be space exposing the sclera at the limbus. Now, when you see exposure of this superior limbus, it means the patients have proptosis, okay? There is lid retraction, okay? And this is as a result of sympathetic stimulation of the levator palpebral superioris. And by the way, you should know that the levator palpebral superioris is a molar muscle. It has dual nerve supply, both from the autonomic and the somatic supply. Now, from the autonomic supply makes it to remain in a partial state of contraction, which will cause lid retraction. Now, if there's exposure of the inferior limbus, this is the inferior eyelid. If there's exposure of this limbus, that is between the cornea and the eyelid, there's exposure of the sclera, the patient will have exophthalmos. Now you should go and check the various grades. Assignment, go and check the various grades of exophthalmos. Patient will have infrequent blinking, lid retraction, lid lag, okay? When you demonstrate lid lag, the eyeball will roll faster than the eyelid for the same reason. There's proptosis, chemosis, conjunctivitis may occur. There's pretibial, periocular swelling, and corneal ulceration because of the persistent exposure of the cornea. And exophthalmos, the eye is always exposed and not well lubricated. Okay. Now, exophthalmos, okay, it is proptosis of the eye caused by infiltration of the retrobulbar tissue with fluid and round cells with lid spasm of the upper eyelid from sympathetic stimulation of the levator palpebral superioris. Sclera can be seen clearly below the limbus of the eye. Proptosis can be measured by exophthalmometer. Severe exophthalmos, malignant exophthalmos, is a misnomer, okay? It requires large doses of steroid, antibiotics, and orbital decompression. The grading is mild, moderate, severe, and progressive exophthalmos. Okay, now we'll talk about the toxic multinodular goiter or the plumber's disease. This is a secondary thyrotoxicosis. We've talked about the Graves' disease, which is a diffuse, okay, toxic goiter. Now we'll talk about toxic multinodular goiter. It occurs as a complication of long-standing simple goiter. It is commonly seen in endemic areas, okay? These patients already have a long-standing goiter in an endemic area, and it now transformed into toxic goiter, maybe as a result of ingestion of large doses of iodine. And that phenomena is termed Jod-Bestow phenomenon. Toxic multinodular goiter is a disease of the elderly and is less severe than Graves' disease. The transition from non-toxic to toxic nodules involved the development of functional autonomy of a nodule. Administration of iodide can also lead to development of thyrotoxicosis in both endemic and sporadic goiters. So if a patient have goiter, there are even some limitation in the investigations you do, like iodine containing contrast, so that you don't trigger toxicosis in them. The clinical presentation, it may present as an enlarged nodular thyroid with compressive symptoms, dysphagia or dyspnea. Cardiovascular involvement is more common than eye involvement. So they have arrhythmias, atrial fibrillation, congestive cardiac failure. So they can present with thyrocardia. Weakness and wasting of the predominant weakness and wasting are predominant with loss of appetite, hepatic thyrotoxicosis. Now, you could also see a patient presenting with a toxic nodule. A toxic nodule, we said that Graves' disease, toxic multinodular goiter, and toxic nodules are the commonest entity of thyrotoxicosis. Okay? Autonomously functioning thyroid nodule, these are nodules that function independently of the normal pituitary. Okay? They are autonomous, independent of the normal, okay, pituitary. You have toxic adenomas. These nodules usually cause hyperthyroidism and suppresses the secretion by the pituitary via a negative feedback. Hence, extranodal tissue becomes functionally active. They manifest clinically when the diameter exceeds 3 to 4 centimeters in size. These are other variants of thyrotoxicosis. There could be thyrotoxicosis factitia. It occurs due to ingestion of large amounts of thyroid hormones, most commonly seen in women with underlying psychiatric disorder and in the hospital. They just take thyroxine, large doses of thyroxine. It could follow trophoblastic tumors, elevated levels of serum, total and free T4 and T3 is frequently seen in patients with choriocarcinoma or hydatiform mole. A circulating thyroid stimulator of trophoblastic origin, possibly HCG, causes the thyroid hyperfunction. There could be ectopic thyroid tissue or stroma ovarian may occasionally give rise to thyrotoxicosis. So we are going to stop here, okay? Our next lecture, we are going to be dealing with the management of these conditions, where we are going to talk about the investigations of these conditions in detail. Then we'll now talk about the management. So now we are going to entertain questions. So if you have any question, you can ask. Thank you for participating. So any question?
Hello, sir. Yes, sir. Thank you, sir.
Yes, welcome.
Yes, I just need some few clarifications.
Okay.
Yes, sir. From what we are saying here, the risk factors for most of these diseases, apart from the specific ones, maybe inflammatory and then the malignant,
Yes.
iodine deficiency or excess iodine,
Yes.
then maybe usually from environmental issues, maybe mountainous area,
Yes.
and maybe goitrogens in food.
Yes.
Prevention, I see that we have in our salt and maggi are usually iodine.
Yes.
Like,
Okay.
don't talk of thyroid diseases.
Your question is not clear.
Internal medicine.
Your network is not stable. I did not get your question.
Trying to say that's internal medicine.
What is your question?
Medical treatment. Is there any medical treatment for thyroid diseases? Do physicians handle? Like, if a patient comes to you, can you make the goiter regress if
Okay.
so it's still diffuse and then not maybe?
Okay. I believe you are trying to ask concerning medical treatment of thyroid disease.
Yes, sir. Does it come the problem in some aspects?
Okay, we are going to discuss extensively the management of the thyroid diseases. Of course, there are medical treatment of thyroid diseases like toxic goiters. There is the medical treatment which we will discuss extensively. And you will see that some of the drugs, aside reducing the symptoms, they also have some immunological effects, anti-immunological effects, function. They tend to reduce the gland a little, but there's no complete regression of the gland, and there's high risk of recurrence following medical treatment. But just reserve the question regarding the management. When we get to that level, we are going to talk extensively on the treatment of this condition. Yes, any other question? Any other question? Okay. It appears there are no questions. So we are going to continue with the other aspects of the lecture since there are no question in our next session. So thank you very much for participating. We are going to stop here.